Hi everyone, good night. Tomorrow we have another specialty VMR, and this time we'll be focusing on rheumatology, actually, aka the best specialty. So I'm going to start with some introductions. First, Dr. Lara Arneson. She's a rheumatology fellow at Northwestern University, and she completed a medical school at Emory University and internal medicine residency at Northwestern. Her interests include medical education, health equity, baking, and rolling slowly along Lake Michigan. Thank you so much for coming.
Thank you. Delighted to be here.
Dr. Lara, maybe you could talk a little bit why you chose rheumatology, what did you prefer outside of medicine?
Yeah, I think rheumatology really encapsulates the best parts of internal medicine and just magnifies them. We get to solve really interesting clinical challenges, the most mysterious cases in the hospital. We get to develop really longitudinal relationships with our patients. We get to think about the patient as a whole person and integrate all of the different systems in the body. And we have incredible supportive colleagues.
Sounds incredible. Thank you. We also have Dr. Brian Generos. He originally hails from Cleveland, Ohio, and he completed both medical school and internal medicine residency at New York University Langone Health before returning back to the Midwest for rheumatology fellowship at Northwestern. Within rheumatology, his areas of interest include medical education, inflammatory arthritis, and vasculitis. And outside of the hospital, he can be found working out, planning his next travel destination, and daydreaming about adopting a golden retriever puppy. Thanks so much for coming, Dr. Brian.
Thanks for having me. I'm excited to be here.
And what about you, Dr. Brian? What did you perform outside of medicine and why rheumatology?
Yeah, outside of work, I mean, I do love to travel. My next trip is actually next week. I'm going to Hawaii on vacation, which I'm quite excited about. And I chose rheumatology because it's the best. Honestly, I was like pretty obsessed with House, that show, before I like started medical school, and like all the diagnoses, like the coolest ones were always rheumatology. So I was like, oh, it's like that sounds legit. And then it proved to be true, like in the hospital and medical school and residency, all my favorite cases, all the most interesting cases that I thought were just so diagnostically fulfilling were the rheumatology cases. So I love the detective work. I love the people. Everyone's so friendly, so nice. And it gets rated by Medscape as the happiest self-reported specialty. So if you don't believe me, believe Medscape. But thanks for having me.
Thank you for coming. And last but not the least, Dr. Nisha Jewell. She's an associate professor of medicine in the Division of Rheumatology, director of the Northwestern Vasculitis Center, and director of the Rheumatology Fellowship Program at Northwestern Medicine. She completed medical school and a master's in public health at George Washington University, followed by residency and fellowship training in rheumatology at Rush. Dr. Dua currently leads a multidisciplinary team in the clinical management of vasculitis patients and is expanding the clinical and translational research initiatives in collaboration with the Vasculitis Foundation at Northwestern. Thank you so much for coming.
Thank you, Rafa. That was a mouthful. I'm excited to be back. I know I did a case with two of my other fellows a while ago, and it was really enjoyable. You guys have great questions, and it's really just fun to walk through these interesting cases together. So thanks for having me, and I'm excited to do this with Brian and Laura. Two fabulous.
Thank you so much for coming.
Of course.
It's such a nice experience to have you back. I just wanted to ask you as well, like why you chose rheumatology and what you perform outside of medicine.
I like lots of things, and so I feel like rheumatology covers lots of things. I felt like it was like constantly, it was a field where the more you learn about it, the more interesting it got, which I didn't find that to necessarily be the case in some other areas of medicine. I mean, medicine is fantastic and you're touching people's lives and you're making a difference and it's wonderful. But I felt like in rheumatology, the more I learned, the more I wanted to know and the more interesting it got. I felt like I was, meeting really cool people. The mentors are a huge part of it. You just find the people you connect with. The patients are very resilient. You have such a variety of cases and you're always kind of piecing together things. And I don't know, it's very cerebral, but it's a bunch of like really fun nerds working together. And so I love it. I don't know. That's about it.
Oh my God, I love that definition. Thank you. This couldn't be happening without the help of our incredible team members. Mukund, could you please introduce yourself?
Yeah, hey team, I'm Mukund. I'm a third year medical student at UCSF. Nice to meet everyone.
And what do you do for fun outside of medicine?
So yeah, I'm super into astronomy. So if you all don't know, there's a comet out right now. It is not naked eye visible, but if you have binoculars, you can see it even in the city. So go check it out. It's up at like 3 a.m.
Wow, thank you. So how about Jasmine?
Hello, everyone. I am Jasmine. I am a medical graduate from Mexico, and I am currently preparing for the step 2. And yeah, that's basically it. And what I like is plants. I like plants a lot.
Yeah, we can see that. They're so beautiful, by the way. So maybe Jasmine, could you please share your screen and then we can start. Dr. Lara, and whenever you're ready.
All right, let's get started. So I'll be presenting a case today. This is a 42-year-old woman with a history of hypothyroidism who's presenting to the hospital with subacute lower extremity pain and acute lower extremity numbness and weakness. So to provide some context, she was feeling very well, healthy until about 2 months prior to admission. At that time, she developed new onset pain in both ankles, which progressed over the course of a few weeks. It was worse with prolonged standing. Both her feet and both her legs were hypersensitive with pain to light touch all over the legs. And then what really prompted her to present to the emergency room was, for the past week, she's developed numbness throughout both feet and both legs, along with some weakness in the ankles, which has led her to have several falls at home and really made it difficult for her to walk.
Very, very interesting article. Do you feel like it's a good place to stop, or?
If anyone would like to add any comments or ask any questions, feel free. Otherwise, I can keep going with sort of a review systems and some other history.
Dr. Dua, Dr. Jaros, do you want to ask anything?
Well, I mean, I think we'll probably get a little more history, but I think we're clearly discussing something where there's a combination of, weakness, maybe some sensitivity loss, sensory loss, right? Because she's talking about some of those paresthesias, and then pain. And so it seems like there's multiple areas involved. So those are probably the things that would stick out, at least in terms of this little piece right here that you're going to hone in on, and obviously try to figure out what they're associated with. But I think we can keep going unless there's specific questions on it.
Mm-hmm.
Yeah, I feel like we could ask you, as a primary care doctor myself, I feel like weakness is such a broad subject. Like, if you have a patient presenting with you with weakness, like their chief complaint, how do you approach such patients?
That's a great question. Brian, you want to try?
Yeah. The first thing that comes to mind, especially in this patient, is I think differentiating weakness that's characterized by pain versus weakness that is kind of like true either muscular or neural weakness is an important point. A lot of patients will present saying they feel weak, but when you start to tease it out either by history or by exam, you find that maybe pain is actually what's limiting them and not actual like muscular atrophy or disuse or something like that. And so the differential kind of is very different depending on whether you're thinking this is related to pain or true weakness. And so that's one thing in the exam I'd want to understand and I'd be curious about in this patient. And sometimes with people in pain, it actually takes quite a bit of like coaching, and on exam you do kind of have to like really encourage people to like show you how strong they can be in order to get an accurate assessment of what actually is going on. I think two other things approaching weakness. One would be the acuity of onset. More acute onset weakness, I actually tend to think often less in terms of some of our processes, like our immune-mediated myositis or things like that tend to occur, more insidiously over weeks to months, whereas something like drug-induced or a traumatic event, I tend to think of as being a little bit more acute. Similarly, when you're thinking in the rheum world about myositis, the presence of pain coexisting with the weakness is a little bit unusual. Typically, when we think about dermatomyositis or inclusion body myositis, these things tend to be painless entities, and so the presence of significant pain kind of makes me think that's a little bit less likely. And then the last thing I would mention that Dr. Dua was kind of touching on is that in this patient, sensation is involved as well as motor function, which really points me more towards kind of like a neural or nervous system kind of etiology that could affect both of those.
Excellent points, Brian. I see also some excellent questions people are asking in the chat about, symmetrical and progressive. To provide a little bit more context on review of systems, she does endorse that she's had fevers at home for a couple of days, as high as 103 that she measured at home. She has no upper extremity pain, weakness, or numbness at all. Her symptoms are all in the lower extremities. As rheumatologists, we're always interested in joint pain, stiffness, and swelling. She denies any localized joint involvement. Her symptoms are really diffuse throughout both legs, kind of starting in the feet, the ankles, and now more broadly in the legs. And she denies any night sweats, any weight changes, any bowel or bladder incontinence, any saddle anesthesia, no rashes. And then going into some specific review of systems questions we ask in rheumatology. Specifically, she has no history of Raynaud's, no dry eyes or dry mouth, no oral or nasal ulcers, no hair loss. Also no chest pain, dyspnea, cough, bloody urine or foamy urine, or swelling of the lower extremities.
So Dr. Dua, what goes into your mind with this additional information?
So I think Brian did a great job of talking about like what, how to kind of tease out weakness. And of course, you're thinking about pain versus actual true weakness and trying to figure that out with the physical exam. I think these clues, the fever obviously makes you concerned about a more acute sort of trigger or an infectious process that could be going on. Some of our autoimmune diseases are associated with fevers. They tend to be lower grade, but that's something that you would think about with the fevers. It seems more localized, right? Because she doesn't have upper extremity symptoms, no night sweats, so it's less, you're not thinking as much about a long onset, long-standing malignancy that can maybe, you still think about it, but it makes it a little bit maybe less likely with the timing. No incontinence, of course, with numbness in and possible weakness in both extremities, you worry about, and a fever, you would worry about something like a spinal abscess or something like that, right? Anything that could be pressing on the nerves and causing bilateral symptoms that's sort of been growing over a period of time. Of course, a metastasis or tumor could do that, but she's been healthy up until this point. It's still in the differential. And then the other comments are more about no localized joint involvement. So, people can get definitely inflammatory arthritis in both of their ankles after an infection, like a reactive arthritis type of process. So with fevers and joint involvement or inflammation, you might think about that. But she doesn't seem to have local joint involvement. We'll learn more, I guess, like in the physical exam about what exactly is going on with her lower extremities. And then, of course, the rest of the review symptoms points towards things that we usually look at in a lot of our autoimmune diseases. So, oral ulcers, nasal ulcers, hair loss, these are all things that we think about with lupus, dry eyes, dry mouth, we think about Sjogren's. And then the kidneys can be affected in many of our diseases. So that's kind of why we ask about the, blood in the urine or the foaminess in the urine that would be there from proteinuria. So those are the things that would kind of come up in my mind with those additional comments.
Yeah, excellent breakdown. Thank you. Dr. Brian, anything else you'd like to add?
No, I would just say that owing to our diseases, I think this underscores a point of how even with a complaint like weakness or a generalized complaint, you'll see rheumatologists always tend to go through a variety of systems and questions that, superficially may not seem related to the complaint at hand, but really what we're trying to do is identify if multiple organ systems are involved that kind of can cohesively tie whatever the chief complaint is into, one unifying diagnosis. And that can be difficult because, a lot of our diseases tend to be so systemic and heterogeneous in that way. But I think including all that information is really helpful in terms of helping narrow our thought process and differential.
Another question, does the past medical history of hypothyroidism change your differential somehow?
Yeah, I mean, I think two things with the hypothyroidism. One, some of these symptoms, perk up my ears and make me think if her thyroid disease is not well controlled, that's a good reason to have paresthesias, weakness. The fever is a little unusual, but certainly one of the first, labs I would want to hear about is what her thyroid function studies look like. The other, point would be that wondering whether her hypothyroidism is, kind of a true kind of autoimmune mediated hypothyroidism, which, would impact her case in that she may be more at risk for other autoimmune disorders. And then often what comes up is inevitably if an ANA is obtained, we may see that's positive, and that will need to be interpreted in the context of having, another autoimmune disorder, which alone could be associated with that lab value.
Thank you.
All right, are you ready for more information? Rounding up.
I was just going to say there's definitely a couple of comments in the chat where people are making a few suggestions. I'll just throw them out there so in case people can't see them.
Absolutely.
So there was some questions about symmetrical or not and progressive or not. So there was some progression, right? But at the time that we saw her or that she presented, she had just sort of had it in her lower extremities, kind of to mid calf, or I guess we'll get some of that with the physical exam.
Correct. Yep. So bilateral, symmetrical, gradually progressive. At this point, it's about equal bilaterally, subjectively, and up to primarily in the lower legs at this point.
Okay. And then there was some questions about Guillain-Barré, and people are throwing out some interesting comments about that, but we'll talk about it.
Great thoughts, no comment. So rounding out the past medical history, it's just hypothyroidism. Her only home medication is levothyroxine. Family history, really no significant known family history, including no known history of autoimmune or rheumatic conditions, no history of a similar presentation in a family member. Then in terms of social history, so this is taking place in Chicago, but she was born in Mexico, last visited there a few months prior. No other recent travel, specifically no significant time spent in outdoor or wooded areas, no alcohol, tobacco, or drug use. She works in the service industry and has no known occupational exposures.
Could you please give us the physical exam?
Absolutely. So moving on to our exam, she is in general well appearing. She is laying in bed in no acute distress. Her sclera are white, no icterus or injection. Her mucous membranes are moist, no oral or nasal ulcerations. In terms of her cardiovascular exam, she has a regular rate and rhythm, no murmurs, no rubs. Her lungs are clear bilaterally. She's on room air. Her abdomen is soft and non-distended with normal bowel sounds. She has no synovitis appreciated of any joints, no joint deformity, no joint effusion, warmth, erythema, or tenderness. And her extremities are well perfused, no edema. She has 2+ radial interstitial pulses. Also circling back to her vitals, she is afebrile. Her heart rate is 85. Her blood pressure is 122/81. Respiratory rate is 16, and she's sat in well on room air. Then digging into our detailed neuro exam, which I am sure you're all eager for. Starting with her cranial nerves, 2 through 12 are intact. Reflexes are absent in both ankles. They're 1+ in both knees, 2+ or normal in the biceps and triceps, and she has normal Babinski's. Strength is 5 out of 5 throughout both upper extremities. In the left lower extremity, she has normal hip flexion, 4 out of 5 knee flexion, normal knee extension, 0 out of 5 dorsiflexion, and 0 out of 5 plantar flexion. Then moving on to the right leg, 5 out of 5 hip flexion, 4 out of 5 knee flexion, 5 out of 5 knee extension, 1 out of 5 dorsiflexion, and 4 out of 5 plantar flexion. And then moving on to sensation, to light touch, sensation is absent in both the bilateral dorsal and plantar feet, the bilateral anterior shins, involving the lower third of the shins, and the bilateral anterior ankles. She has diminished sensation, about 20 to 40% in the mid to upper shins, near normal sensation at the knees, and sensation is intact at the thighs and the rest of the body. For proprioception, it's absent in the bilateral first and fifth toes and ankles. And her pain sensation is absent in the bilateral feet and ankles, and diminished about 50% at the lower legs to the knees.
Wow, it seems like I'm pretty much a remarkable physical exam except for the neuro. So maybe Dr. Dua, what are your thoughts?
Yeah, no, so it is a completely normal physical exam except for the neuro exam. And this highlights kind of why I went into rheumatology, not specifically because of the neuro overlap really, but because it affects many systems, right? Our diseases affect multiple different organ systems. And so it is always interesting to always be in touch with many other specialists and make sure we're doing really thorough physical exams. So it's another plug for going into rheumatology. Again, this reinforces that there's no involvement of the upper extremities. You have both sensory and motor deficits, which I think is something that we need to think about, and what could cause sort of both of those problems at the same time. And I'm just trying to look at the differences between both sides. So, sorry, it's really small writing. I'm just trying to look really closely. So we've got 0 out of 5 on the left side, and definitely some more strength on the right lower extremity. So there's a discrepancy. I mean, so when you're thinking about, ascending paralysis, of course, it doesn't always go up at the same time exactly, but, Guillain-Barré was thrown out in the chats. So you're going to think about nerve or muscle involvement. You've got some abnormal reflexes, so potentially one or both, and then something that's not completely symmetric, even though it affects both sides. But I know that Brian's worked on some of this type of stuff before, so I'm going to have him actually comment a little bit on some of the neurologic exam and what it makes him think about.
Yeah, sure. Yeah, I agree. I think it's like an important distinction that she does have significantly better plantar flexion on one side compared to the other. It's a subtle asymmetry, but I think when we're approaching kind of bucket of peripheral neuropathy is trying to understand proximal versus symmetric, distal versus proximal, symmetric versus asymmetric is helpful in narrowing down the differential. Another kind of like localization we think about is upper motor neuron and lower motor neuron. So we see that she's hyporeflexic and she doesn't have a Babinski's, which maybe points us more towards peripheral lower motor neuron disease. And then when we think about kind of acute onset, really what she has is almost like a bilateral foot drop that is asymmetric in both sides. That kind of perks your ears up for mononeuritis multiplex, or I think the new term for it is multiple mononeuropathy, which essentially is just saying that instead of one symmetric distal process, you're getting scattered, variable, asymmetric damage to individual peripheral nerves. And the most classic you think about more like very discrete areas of the body, like wrist drop and then a foot drop, and they're on different sides. That's kind of like the textbook example. But what's kind of interesting is in reality, you get patients like this where it tends to be a little bit blurred and less starkly contrasted. But I think that asymmetry and motor discrepancy, in addition to the acuity of her presentation, definitely makes me think of mononeuritis multiplex as the process that's going on here, which then kind of like opens up a differential that should follow if you're concerned for that process going on.
And in the rheumatology world, some of the early things that are going to come to mind are going to be things like vasculitis or lupus, and things that can, affect obviously the nerves and the muscles with a lot of inflammation. I mean, again, there was that high fever. I don't know if that's more of a red herring and she just had some more low-grade fevers, which can happen with systemic inflammation. When we think about vasculitis, we do see fevers. You can get a mononeuritis in some of the ANCA vasculitis, polyarteritis nodosa. You can definitely get mononeuritis. And you also think about, the reflexes here are different, but you think about things like transverse myelitis, stuff that can affect the nerves, right? And with systemic inflammation, that can happen. So I think teasing it out, of course, we'll talk about what kind of workup we do serologically or EMG wise, are trying to figure out how to localize the lesion. And Brian talked a little bit about upper motor neuron versus lower motor neuron. But I think those are some things that would probably, from the rheumatology side, the disease states that would kind of pop up quickly in our mind.
And specifically for this patient, if you're being consulted about it, what would be your next steps, like in terms of workup?
Yeah. So in terms of approaching mononeuritis multiplex, there's kind of a lab workup that starts to get implicated in that. From our world, like Dr. Dua mentioned, lupus or the primary vasculitis are sort of where our mind's at. Also rheumatoid arthritis in the right context, which this patient has no joint symptoms, but an ANA with a reflex to a more specific, disease panel or other like lupus type serologies would be reasonable, as well as ANCA serologies to evaluate for vasculitis. One of the things you'll always, or you might hear a rheumatologist say is, in addition to our stuff, we're always looking for infections and for neoplasm, excluding the cause of these other things that tend to mimic our diseases or vice versa. So, infectious workup with her fevers, blood cultures. I think it was mentioned she didn't have any travel, but Lyme disease might be something to think about, HIV, and anyone that could be at risk. If any signs of neoplasm or evaluation for that, SPEP might be reasonable to send in her as well. Basic labs would be helpful because even on those, we tend to see some abnormalities in our diseases, like in lupus, for example, looking for cytopenias, any AKI, a UA to look for hematuria, which can be microscopic and not obvious, which obviously could be both lupus or the vasculitis. And then down the road, you're thinking about, I think, imaging wise, looking at the central nervous system and ruling out the presence of any lesions there. And then definitively an EMG to better characterize whether this is a process with the axons themselves that are damaged versus a demyelinating process, which people have kind of brought up CIDP, I think, in the comments, as well as Guillain-Barré, which would be kind of the demyelinating pathway versus an axonal process, which we think of more for the vasculitis or connective tissue disease associated mononeuritis multiplex.
And I had like cryos, inflammatory markers, and of course there was a couple comments in the chat. I mean, she's got hypothyroid. We're obviously going to recommend that they check some of her, her thyroid function, which can lead to hyporeflexia. The regular, symmetric polyneuropathy workup with RPR, TSH, B12, folate, your usual baseline stuff. Clearly we're invited, so it's gonna have a little bit of a different bent, but we obviously want to keep in mind all the other possible things that could present this way.
Thank you so much, Dr. Dua. Could you please go with the case, Dr.
Yes, let's proceed with some labs. I'll provide the context that we don't have any prior labs on file for this patient, so we don't know what is her baseline. Her CBC shows a white count of 7.8, a hemoglobin of 10.8 with an MCV of 85. Her platelets are 331. On the differential, the white count is neutrophil predominant with an absolute lymphocyte count of 0.9, no eosinophils. Her chemistry shows a creatinine of 0.57. The rest of her electrolytes are normal. Her liver panel is notable for an albumin of 3.4, normal being 3.5, otherwise normal, transaminases. Her urine pregnancy test is normal, negative. Her ESR is 137. Her CRP is 105.8. Our upper limit of normal is 10. Her TSH is 1.84, which is normal. Her B12 and her folate are also normal. She has a urinalysis that shows 20 ketones, no red cells, white cells, or casts. I can pause there or continue with a few more specific labs.
I mean, there's a lot of inflammation here, right? I think that's what this is showing us. There's clearly some concern with the SED rate and CRP being that high. CRP being that high, it's very acute, right? There's a really quick increase and decrease with CRPs. SED rates, we tend to think about as a little bit more of like a nice bell curve where it rises with inflammation and it comes down a little bit slower after whatever the event is that triggered it. But we definitely see systemic inflammation with those markers, and we love those markers. I love those markers, but they don't point us exactly towards what the underlying process is. It just shows us there's inflammation. But the rest of her labs look reasonably okay. I mean, her differential is neutrophil predominant. That makes you think about infection when you've got someone with fevers. Absolute lymphocytes 0.9. What is it? Is that low, Laura? Sorry, you're muted right now.
Just below the lower limit of normal.
Okay. Yeah, I think we can get some more labs.
All right. Now for our favorite, the autoimmune serologies. She has an ANA that is 1 to 1280 with a homogeneous pattern. Her C3 is normal at 87. Her C4 is low at 9. And then in our system, when you order an ANA, it reflexes to the rest of the autoimmune panel. So the notable findings on that panel are a positive double-stranded DNA with a titer of 1 to 80, a positive RNP antibody greater than 8, and a positive Smith antibody of 6. So both of those are significantly positive. Otherwise, the rest of the panel, including SSA, SSB, Jo1, SCL70, cardiolipin, beta-2 glycoprotein are negative. She also has a negative rheumatoid factor, negative cryoglobulins. ANCAs were also sent. She has a negative C-ANCA and P-ANCA, corresponding to a negative PR3 and negative MPO. And then she also has a number of infectious studies that are sent. She has a negative HIV, negative syphilis, negative West Nile serologies, normal Lyme serologies. Her quantiferin gold is indeterminate. And she also has a lumbar puncture if we're ready for that. The LP shows in the first tube, 1 nucleated cell, 366 red cells. Second tube, no nucleated cells and 4 red blood cells. Her protein is 17, her glucose is 52. The bacterial culture is negative, and there's a negative meningitis BCR panel. The only notable finding is a absolute IgG value that's elevated with a normal index.
Dr. Brian, what do you think right now with these results?
Yeah, so really interesting. The ANA, I think the first thing to note is, ANAs come in titers. I was always confused about titer values when I was in med school and even into early residency, but basically the higher the number, the more dilutions it takes to kind of get a quantifiable amount of that test in the lab. So 1280 is a high number of dilutions, aka a very significant value of that antibody that's being tested. The titer to us more so matters in the sense of kind of like a cutoff. So a lot of times patients will come back with an ANA titer of 1 to 40 or 1 to 80, which is very low on the spectrum of significance. And those, for us tend to not be, as alarming or as, significant as in terms of like concern for lupus or something like that. 1280 is quite high. As I mentioned before, the hypothyroidism alone could, be related to an ANA, but what's interesting for her is she has a lot of more specific antibodies as well. So the anti-Smith, the positive dsDNA, and the low complement in constellation with an ANA definitely all raise my suspicion a little bit for a lupus-like phenomenon. RNP is interesting in that it can be seen kind of in like a mixed connective tissue disease type state where someone's not fully falling into lupus or scleroderma or myositis, but has a little bit of features of each. But in combination with the other serologies that she has, I think that points me a little bit more towards wondering about lupus. And then looking at the other lab values for anything else that might support something like lupus would be an anemia that is, not well explained in an otherwise pretty healthy young person, and borderline low lymphocyte count, which also can be seen. Otherwise, we have the negative ANCAs, negative infectious studies, and an LP that is pretty bland. So right now I would be wondering, could this be something, a new presentation of lupus manifesting with these symptoms?
Brian, I think you did a really great job going through some of those serologies. I know there was some discussion before we actually came on, just in the background, about how we should order blood tests when we're thinking about rheumatic diseases. And I think, as rheumatologists, we're always going out and saying, don't order random ANAs because they're not going to be useful. And I think that is an important point because, 1 out of 5 people can have a positive ANA and not have an underlying connective tissue disease, and it leads to a lot of stress, anxiety, workup that's not necessary. Just a lot of wasted resources on both the patient and provider side. But at the same time, we also want the serologies exist for a reason, right? So they're trying to help us sort out what exactly is going on, and the pathophysiology of the disease process will manifest as those different serologies. So, that ANA test by itself, as Brian said, it doesn't give you a diagnosis, but it does make you look a little bit closer, especially when you've got sort of other symptoms that could be consistent with an ANA-associated disease. That's a high titer. You can have raging lupus with a titer of 1 to 80. You can have no disease with a titer of greater than 1 to 2,560. We don't hang our hats on one of these numbers or serologies definitively. It's always a combination, again, of the blood test, the clinical story, and everything else that goes into sort of evaluating a patient. But it should make you think about those things. So the positive ANA, sorry, was that a positive Smith and anti-RNP, right, Laura?
Correct.
RNP is one that we associate with mixed connective tissue disease. Smith is pretty specific for lupus. And so it does, again, make you think about some of those disease processes that Brian mentioned. And actually, I know that this is not a typical format, but I noticed that there's a participant on here that is watching this who is a colleague of mine who's who runs a lupus center. So his main expertise is in lupus. And I don't know, Rafa, can they unmute their mic and make any comments? Is that possible?
Yeah.
Yeah, okay. Al?
Surprise. I know some of you. It's good to see you, Brian and Laura. It's funny. I think when the neuro. So I'm going to back up. The lab part, I totally agree with. And to be honest, I was actually a little bit surprised to see the complements to be C4 to be low. I anticipated them to be normal, even if this was lupus. Remember, your C3 and C4 are also acute phase reactants. So while you're consuming them in the periphery with inflammation and it's depositing on your own organs, your liver is making a ton of it at the same time. And the majority of flaring lupus patients will actually have a normal C3 and C4. So don't let that throw you off. I think that's a really important lesson about complement levels. Alternatively, you can have falsely elevated ESRs if you're dramatically anemic, because you just have less red blood cell compression. I'm going to ESR here, but with ESRs is another tricky one to interpret, because if you're really anemic, you'll always have a high ESR because you just have less red blood cells to pack. If you could have a falsely low ESR because you're not making enough acute phase reactants in the liver in cirrhosis, or if you have some sort of enteropathy that prevents you from absorbing proteins. The clinical presentation would not make me think of lupus at all, which is kind of problematic. I mean, it does. It's part of the differential. And this is kind of where I look at the labs for myself. And even though they're ANA double-stranded DNA and Smith positive, which on a board exam would be definitely lupus, I am still tempted to call this an undifferentiated connective tissue disease if I were moving in that direction. The attendings know that you will often diagnose them just so they can get the right medicines. Sometimes, and in this case, if I needed to make sure that they had a lupus specific medication that you needed the diagnosis, I would label it as lupus. But actually at this point, the only clinical symptoms and signs are all neurologic. Usually I'd want multiple systems to be affected for me to call this systemic lupus. And so that's kind of my thoughts about the case so far.
Thanks, Al. All right, we'll go on. I appreciate it.
Fantastic input. Thank you for jumping in. We will move on to the imaging, starting with an MRI of the spine. So ultimately, she ends up having the entire spine imaged. And really, it shows no significant spinal canal stenosis at any level, no abnormal cord signal or enhancement in the distal cord or the conus. Just a few mild degenerative changes at a few lumbar and cervical levels, but nothing significant. It incidentally notes an increased number of retroperitoneal and iliac lymph nodes, which are nonspecific. The largest is 1.1 centimeters. She also has an MRI of the brain, which shows no significant abnormality. And then we had a request for an EMG, which we do have. It's notable for superficial perineal sensory nerve responses that are decreased on the right, absent on the left. Posterior tibial nerve motor responses are absent bilaterally. The peroneal nerve motor responses are abnormal, more so on the left than the right. The upper extremity nerve recordings are normal. So in conclusion, looking at the amplitudes of the motor and sensory nerve responses, which are decreased with a normal conduction time, this is overall consistent with an axonal injury. I'll allow Brian to discuss here if you'd like to.
Yeah, thanks for that info. So a couple things. The spine picking up, these lymph nodes is always troubling, when you find something you weren't exactly looking or setting out to get. I think in the context, of malignancy being on the differential, you do kind of wonder, could this represent pathologic lymph nodes with some kind of hematologic malignancy? Or is this just, she's clearly profoundly inflamed, looking at her ESR CRP? Are these kind of, what we would call non-specific reactive kind of lymph nodes that are just there because her immune system's, kind of angry and worked up. Thinking about the EMG, I think kind of like we were talking about before, understanding whether her process is more axon mediated versus demyelinating is a helpful next step in diagnostically trying to understand what's going on. I think since Laura mentioned that the conduction speeds were normal, some of these processes that were being thrown around in the group chat, like Guillain-Barré and immune mediated, demyelinating polyneuropathies become much less likely. Again, I think when you have someone with, acute onset mononeuritis multiplex with axon injury, that does kind of raise our suspicion for some of these processes that can be associated with our diseases, specifically for a vasculitic type neuropathy, where actually the blood vessels are the pathologic or inflamed process with then sequential infarction of different nerves leading to that mononeuritis multiplex pattern. And there's a couple things, in the history that make me think that, which would be the pain that precedes her weakness, which you don't see in a lot of processes, but is overwhelmingly tends to be the case in vasculitic neuropathies. And also the presence of, additional constitutional symptoms, the fevers that she was having before. So, question mark, like Dr. Kim was saying, whether this, really manifests as, fulminant systemic lupus, but I do wonder with her serologies if she has some type of autoimmune process going on in the background that's leading to a vasculitic neuropathy manifesting with these findings.
Fantastic analysis, Brian. Anyone else have anything to add before I provide some more information?
I think you did a great job.
Great. I will then move ahead to our last piece of information. We have biopsies of the left gastrocnemius muscle, as well as the left sural nerve. And I'm sorry to say, these are actually fairly anticlimactic. The muscle biopsy shows skeletal muscle with mild focal, non-specific myopathic changes. The peripheral nerve bundles captured in the biopsy do not show any evidence of vasculitis, granuloma, or significant acute or chronic inflammation. They perform a lot of special stains, including Congo red, looking for amyloid, a variety of stains for glycogen storage diseases, lipid storage diseases. They find no ragged red fibers, no fibrosis. And the left sural nerve biopsy shows a peripheral nerve without significant histopathologic changes. So that is the last piece of data that we have to share. Would anyone like to discuss before I sort of summarize how this patient was ultimately diagnosed and treated?
I mean, I agree with some of the comments before in that, this is really, we're not seeing a lot of systemic outside of the neurologic system, issues. We have some lymphadenopathy, you have signs of systemic inflammation with the SED rate and CRP, some anemia, the acute phase reactant stuff. The serologies are obviously definitely suggestive or consistent with lupus. Clearly, when you're doing a nerve biopsy, you're hoping that you see something that's going to give you a clear diagnosis. There aren't other serologies or clinical features pointing towards a specific vasculitis. Something like PAN or polyarteritis nodosa, wouldn't necessarily have serologies associated with it, but you wouldn't expect to see, a Smith antibody, and you wouldn't necessarily expect to see drops in complement levels. Cryos, again, you could see a low C4. The cryoglobulin test was negative. The biopsy didn't show much vasculitis changes. But nerve involvement is a worrisome thing, right? Like there are certain organ systems where we tend to be more aggressive and certain organ systems where we tend to be able to say, okay, let's watch and see how someone does. But this lady with complete loss of certain reflexes and falling at home, I think would make me worried, regardless of what the biopsy is showing or not showing. And then there's also the concept that depending on where you're doing the biopsy, you may miss areas of the lesion. So with the serologies and the overall presentation, I would still be worried about like a vasculitic neuropathy associated with an underlying lupus that doesn't have a lot of the other manifestations right now. But, you know, there's a proportion of patients who will present with skin rashes and a proportion that will present with oral ulcers and some that will present with alveolar hemorrhage. And so not every patient with any underlying connective tissue disease presents the same way. So I'd still be worried and want to treat, as long as we've clearly, you know, ruled out infectious causes and malignancies, which is always our sort of caveat. But I think we've done a decent job of that. I know we don't have every single test that was ordered during the stay, but it seems like we've done a good job of evaluating for infectious causes of possible nerve involvement. And, you know, other than, I guess, biopsying one of those lymph nodes, if you're really concerned for a lymphoma, we've done a decent job looking for other stuff. So yeah, I would want to treat.
And how would you treat this patient? Like high dose steroids?
Brian, how do you want to treat this patient?
Yeah, that's a good question.
Laura, wait, sorry, did you have anything to add, Laura, before we talk about it? I didn't know if there was
No,
any.
I can provide a summary of how the patient ultimately ended up being treated, but
No, we'll talk about
if
what
Brian would like to comment first, go for it.
Yeah, go for it.
Yeah, you know, the mainstay, and if, you know, again, assuming that we did a thorough job ruling out infection, malignancy, you know, the mainstay for initial treatment is going to be high dose steroid therapy, mostly because of, you know, the timing, the onset of action, and how quickly we can reduce that inflammation. And like Dr. Dua said, prevent any further nerve injury, which is obviously a huge morbidity to the patient. So this is a patient, you know, who probably I would favor doing kind of like a pulse dose steroid regimen in. So high doses of solumedrol, anywhere from 250 milligrams up to 1 gram for a few days, just to rapidly reduce inflammation. The question then kind of becomes, you know, what do you treat with long term? If we're, you know, approaching this patient like this is an end organ manifestation of lupus, you know, to my understanding, there's not a lot of particular data on drug of steroid sparing agent of choice in nervous system manifestations of lupus. I think there's been, you know, one study that looked at continuing steroids over time versus replacing it with cyclophosphamide, and patients who were on cyclophosphamide instead of long-term steroids did better in terms of, you know, preventing adverse outcomes and problems related to steroids. But I think for the nervous system, we kind of extrapolate from some of the other organ manifestations of lupus, like the kidneys, in which we do often use cyclophosphamide as an agent, depending on the case. So I would probably favor a discussion with her about cyclophosphamide following steroid initiation, pending, you know, some of the side effects and how tolerable those are to her. You know, she's 42. With cyclophosphamide, we think about infertility and risk of, you know, inducing premature ovarian failure. So it would also need to be a conversation with her about if what her childbearing wishes were, if she had the means to do, you know, some kind of egg retrieval storage, if that were the case. And risks, benefits like that are always, you know, kind of shaping, in addition to what we want to use, but what agent actually, you know, gets used.
Yeah,
Dr. Kim has a hand.
Something.
Yeah, you know, I'll just really quickly comment that drug-induced vasculitis was mentioned in the chat. That is something that we always want to consider when we're approaching patients, and it can look exactly the same as a, you know, systemic regular vasculitis. With ANCA-associated drug-induced vasculitis, you tend to see really pan positivity of serologies. So ANCA, MPO positive, PR3 positive, C-ANCA, P-ANCA, you get a lot of just positivity of lots of antibodies with drug-induced vasculitis. That's not always exactly what's going on, but that's definitely a smart thing to consider. With the specific serologies, it seems a little less likely, and she doesn't seem to be on specific meds that can be associated with a drug-induced vasculitis, hydralazine, PTU. There's a couple of different things out there that we think about. But it is something that, it's reasonable to check a UA kind of as part of her, urine drug screen as part of her initial workup if you're thinking about a drug-induced vasculitis. That also being said, you tend to see a lot of cutaneous lesions. And so the presentation usually isn't just nerve, like really, really nerve focused. And then moving back, there was also a question about metro as in methotrexate. So methotrexate is what MTX stands for. Sorry if there's just.
I wonder if that might have been confusion about solumedrol.
I
think Brian was referring to methylprednisolone for those who aren't in the US.
Oh, yes. So when we say pulse steroids or methylprednisolone, that's usually 500, but usually closer to a gram a day for 3 days. So really heavy duty glucocorticoids. And then, management wise, I agree with a lot of things that Brian said. I think it looks like Dr. Kim has a couple of comments and his hand in the air.
Actually, just a question for Laura and Brian. The chat, someone had mentioned very early on, like a Guillain-Barré or an acute inflammatory demyelinating polyneuropathy picture, which this can also look like. And I'm just wondering what made the potential exclusion of that, because that's treated differently. It's an important distinction. With that, you want to do Plex or IVIG. I think IVIG is favored mostly, acutely. So I'm just curious, unless I missed something here, about how the decision to make this more of a mononerized multiplex versus a AIDP picture was made.
Yeah, great question. And coincidentally, at almost the same time, we also had a lupus patient who was being treated for lupus-related CIDP. So it was an interesting comparison. There was a lot of in-depth discussion with the neuromuscular team, ultimately based on the particular pattern of her EMG and the slight degree of asymmetry in her presentation. They ultimately favored labeling this a mononeuritis multiplex rather than a CIDP or a Guillain-Barré type of autoimmune demyelinating. Right.
So Dr. Lara, how you ultimately diagnosed and treated this patient?
So the diagnosis that was ultimately agreed upon was a new diagnosis of lupus, presenting with a peripheral mononeuritis multiplex due to vasculitic neuropathy. The decision was made to treat her with methylprednisolone 1 gram IV for 5 days. She showed some improvement after starting this. Plan was then for her to receive induction therapy with cyclophosphamide. A wrinkle in the plan was that right around the time she was to receive her first dose, she tested positive for COVID. And so that course had to be delayed for about 2 weeks, but she ultimately did start it. She's about halfway through the induction course for cyclophosphamide at this point, which takes several months. And at outpatient follow-up, she's feeling better. She's regained some sensation in both of her feet. She's starting to be able to move her right toes. She's able to walk a little bit. Still has no reflexes in the left ankle, still has a bilateral foot drop, but they're planning to continue the induction course of cyclophosphamide, tapering her prednisone, and starting her on hydroxychloroquine. Some really interesting, really interesting nuances in the diagnosis of this case. As Dr. Kim and several others brought up, this is not at all a typical index presentation for someone to be diagnosed with lupus. I can try to share my screen real quick to show some of the classification criteria for lupus, if that's okay. I don't want to disrupt the screen. And so I'll show, let's see, I'll show here that in rheumatology, we rarely have true diagnostic criteria for our conditions because they're so nuanced and the presentation can be very individualized. But what we do have are classification criteria designed more for research purposes to create a homogeneous cohort. So for lupus, we have the 2017 ACR classification criteria. To even be considered for being classified as lupus under these criteria, you have to have an ANA of at least 1 to 80. As Brian and Dr. Dua mentioned, within the world of rheumatology, that's not a particularly high ANA, but you at least need to have that. And then you can accumulate points in these different categories, clinical criteria and some more laboratory autoimmune criteria. And if the patient reaches a score of 10 points, they can be classified as having lupus. So interestingly, in the case of our patient, she did meet the entry criterion. She had a very positive ANA. For clinical criteria, you can give her points for having a fever. For immunologic criteria, she would get 3 points for having her low C4 and 6 points for her anti-Smith. So ultimately, she meets the 11-point criteria to technically be able to be classified as lupus. You can certainly, with any given patient, you can have a debate among rheumatologists about the ideal diagnosis. But that was the thought process in this patient. I think it's also really interesting to note that under these criteria, all of the neurological, the neuropsychiatric manifestations that accrue points are really for central nervous system manifestations, for delirium, psychosis, seizures, though there technically are some criteria recognized, or some peripheral nervous system manifestations of lupus that are officially recognized. The most common ones being polyneuropathy, mononeuropathy, whether it's single or multiplex, and a cranial neuropathy. Does anyone else have other points to comment on there?
Yeah, I'll just add that, yeah, these classification criteria are helpful to organize your thoughts, but definitely, like you mentioned, we diagnose the disease first and then apply classification criteria if we want to secondarily classify them. It's a really weird point, I think, to a lot of the residents that are in the room of these type of criteria and how we use them. But yeah, it's rheumatology. Nothing is clear cut. I think what I would have done with this patient is I probably would have diagnosed him what we call incomplete lupus. So it's all nuanced, right? But that way it kind of gives us a hedge just in case we're wrong in the future. She may announce herself a little more completely, although you whapped her with some heavy medications, right? And so this may be the max, how she presents in terms of the worst, right? And so organ recruitment can still occur, additional organ recruitment can still occur for the next 5 years post diagnosis. But when you hit them hard at the beginning, it's going to be probably the only manifestation. Did her C4 ever normalize? Only reason why I bring this up is having low C4 is kind of weird because we have anywhere between 2 to 8 copies of the C4 gene in our genome, 1 to 4 for each allele. And so it's a dose dependent thing too. So if you only have 2, you'll always have low C4s, even though you're not activating complement. You have 8, you'll always have high C4s, even though you're massively activating it. So I'm just curious if she ever normalized it, just to give me an idea of, how reliable it is when you just look at the thresholds of normal.
I confirmed her repeat complements were normal.
Okay, interesting. Wow, she was definitely consuming complement then. So that makes me think a little bit more lupusy then. If you're
good, that's what we thought. That's what we treated her for.
Yeah,
so
understood.
I'm glad you think so.
Yeah, you're welcome. I'll log off now. Thanks, guys.
Thanks.
No.
Dr. Rara, I just want to thank you for bringing this case, very complex, but at the same time, we touched base on so many incredible things that related to rheumatology, locus workup and basic workup in general. Also, the fact that you could heavily influence positively these patients in the long term, she's basically regaining her neurofunction, it seems, with therapy, which I think it's ultimately what we in rheumatology love, like to see how this patient first presented and how in the long term we were taking care of these patients. So thank you so much for bringing this case. Dr. Dua, anything else you'd like to add before we finish the session? Like any teaching pearls, anything else?
No, I think this is obviously definitely a complex case. I think you guys will all come across, patients with lupus and new diagnoses, longstanding lupus, and autoimmune diseases, no matter what field you go into. Rheumatology is the best field, but whatever you go into, you will come across different cases of patients with lupus. And it's just important to remember sort of the disease spectrum. Not every patient presents the same way. And I think the main thing I can always stress with any rheumatologic diagnosis is you got to use everything. You got to use your clinical exam. You've got to use your history. You have to use your lab tests. You have to use your imaging or other types of studies, pathology, everything to try to figure out the best way to manage the patient. You're going to try to tailor your treatment based on the organs involved and the severity of the presentation. All of our medicines have risks associated with them. And so deciding to pull that trigger and use a medication in any patient, you just have to weigh the pros and cons of all of that, and be as aggressive as you need to be and find that fine line as, to figure out just where do you draw that line and how can you get the disease under control without hurting the patient. And I think that's, that's what's fun in rheumatology. So there's no straight up teaching pearl, but that's really it.
Oh, it was incredible. It's a reflection from a true long-term rheumatologist. Things that we learn not only on the long term. No, thank you so much. And to finish us off, Dr. Brian, anything else you'd like to add?
I don't know how I can follow that. No, I thank you all for your time. Again, thanks for having us. Like Dr. Dua said, it is a complex case, but I think there's a lot you can learn from it in terms of approach to peripheral neuropathies, understanding the nuances of the diagnosis of lupus. And kind of like you said, this is one of the really exciting things about rheumatology is that, we were able to really impactfully make a difference in her. And, she still follows with us in lupus clinic and, will be long-term one of our patients, and we'll get to see how she progresses and hopefully continues to recover. And that's really rewarding.
I just want to thank you everyone for coming, and such a blast to have you guys here. Hope to see everyone again. So have a very good night and thank you.
Thank you.
Thank you so much.
Bye.